So let's start.
Let's start.
Mm-hmm.
Okay. Good evening, dear friends. Welcome to IVMed webinar. Thank you for your visiting us today. We are starting the special series of educational webinars from IVMed Fertility Specialist. My name is Nadia Milinevska. I am a head of International Department for Customer Servicing, and I'm director of IVMed Family Agency, which serves patients in different types of programs, providing complete support in IVF programs and surrogacy programs, starting from the beginning up to the exit process. Today we have a very interesting topic. The topic is oocytes and age. It is a fundamental problem for those couples who are planning own pregnancy or IVF treatment or considering IVF cycle in a surrogacy program. So, does the oocytes quality change through the years? Or do we have time to postpone our plans to start treatment? Do we have unlimited fertility lifetime? Or should we start treatment now, not losing time? All these answers to questions you will receive today during the webinars. I'm happy to introduce our fertility specialist, Galina Strelko. She's head doctor. She's co-founder of Medical Center IVMed. She's obstetrician gynecologist and fertility specialist. The second speaker is Birol Aydin. He is head of embryology division at Medical Center IVMed. He is official expert of European Society for Human Reproduction and Embryology. So today we have a great opportunity to ask questions to this specialist, not only the question related to topic oocytes and age. You can ask all your questions in active chat. They are specialists in different fields, including IVF treatment, all types of IVF treatment, with egg donation, surrogacy programs. They are practicing specialists in vitro fertilization techniques. By the way, Dr. Strelko developed and practices her own hormonal stimulation protocols, which have a big number of oocytes and outcome, and simultaneously excludes the risk of hyperstimulation ovarian syndrome. She also has big successful experience in making prognosis for endometrial receptivity, which is again important when we talk about the prediction of success in embryo transfer attempts. Birol Aydin is an expert in embryology. He built his career in a big world-famous Australian clinic, and now we are happy to have him in our IVMed Medical Center. He implemented a lot of advanced technologies that are now available at our medical center. For example, the unique technique of oocyte selection and freezing based on precise selection of good quality oocytes that can be frozen, for example, in egg donors, and then successfully sewed and used in IVF cycles. We have a lot of such programs. They are available now at our medical center, and if you want to get more information, you can find it on our website. We also use and practice mitochondrial technique, which helps those couples who have insufficient outcome of egg cells and blastocysts in IVF cycles. And also we practicing microsurgery testicle aspiration when we talk about male infertility factor. So now, before starting our presentation, I would like to announce the next topic of our webinars, which will be held on next Friday. That is COVID-19 and challenges in surrogacy overseas. This topic at the moment, the most important and urgent for those parents who cannot cross borders under quarantine conditions. So we will have the next week the invited speaker Olga Danchenko, who is our partner. She is a lawyer who helps parents in exit process in surrogacy programs, and she will be next week talking about how to cross the border, how to arrange surrogacy process during quarantine. So if you have friends who now at the surrogacy process on final steps or in the middle step, please share the link that we will send you to email and invite them to our webinar. And now we will proceed with our present topic, oocytes and age. So Dr. Galina, please start.
Thank you very much for your kind presentation. Welcome to all participants. I'm very excited to talking today about this interesting and maybe most important topic of reproductive medicine. Today we will talk about oocytes and age, and we will try to understand why it is so important. I'm sorry. This doesn't move. I don't understand why. Dear friends, I'm sorry, little technical problem. I will try to start once again. Okay, so today we will speaking about oocytes and age. We will see different parts of this problem and why it is so important, these relationships between women's age and oocytes quality. So we will see age-related fertility decline, chromosomal abnormalities of gametes, how many embryos need for one embryo transfer of one euploid good quality embryo. We will see which meaning have mitochondria and why mitochondria is so important. And we will also see what we can do else, not medical, but by changing lifestyle or something like that. So, age-related fertility decline, when it is time to worry. You can see the graph and these lines of different color, and you can see in this graph that subfertility start around after 31, 32 years old. Around 40, you will have mostly you will be mostly not able to become pregnant, but before your menopause begin will be around 10 years gap. So we need to understand that before menopause, around 10 years, you will be infertile or subfertile, but you will have more or less regular cycle and no other sign of decreased ovarian reserve. If we analyze the probability to have pregnancy every cycle, you can see that at 22 years old, the average probability to become pregnant is around 25%. At 36 years old, it is around 15%. Generally thinking 35, 36 years old, it is very young woman, pretty nice, but we can see...
Excuse me, Galina, Dr. Galina, just one moment, we cannot see your presentation.
Oh, I'm sorry. I am sorry. I will try to do something. There is some kind of... Okay, Zoom. Once more.
Just select the screen with your presentation.
Yeah. I will try to do this. Like that is better?
Oh, yes, now we see.
Okay, sorry. I'm not very good with technique. So we will return to this slide, and I will show you once more that subfertility starts after 31, 32 years old, sterility after 41, 42. And it is around 10 years because the between the fertility problem and menopause. And we can see here that probability of pregnancy in 22 years old is mostly twice higher than in 36 years old. And I would like to say you that it is not, how to say, modern problem. It was all the time. In this very interesting work, scientists analyzed the fertility in different populations, 10 different populations, young age, 20, 24 years old starting, and different periods. For example, 1921, 1930, Geneva bourgeoisie like 1600, 1649. So it is 400 years ago. For example, Normandy marriage in 1674, 1742. So absolutely different populations, but you can see that their graph of fertility is mostly the same. It is start to decline the fertility, the probability to become pregnant after 32, 33 years old, and became mostly zero after 42, 43. In 2014, American Society of Reproductive Medicine published guideline committee option, and it is very important because it was written officially that decrease of fertility is gradually beginning approximately after the age of 32 years old, and this probability to become pregnant decrease more rapidly after 37 years old. Women older than 40 years old should immediately be treated and investigated because after 40 years old, the probability to become pregnant decreased dramatically. So it is, we know all this, but the modern trend in our life that the constant increase of reproductive age. In our clinic, for example, the average age of first visit is around 38 years old, and it is the same tendency all over the world now. And also, second point, that most of women think that general health and general physical activity are the equivalent of reproductive health, but it is not like that, unfortunately. Also, I would like to show you very interesting investigation about women's awareness about age-related fertility. And these two graphs, black and gray. Black, it is women who have been pregnant before, and in gray, no prior pregnancy. And it is interesting that both groups mostly aware about probability and problem of possible diabetes, miscarriage, hypertension in late reproductive age. But women who never been pregnant absolutely not aware about high probability of genetic abnormality and other health risk. So that's why it is very important to talk in that quality of women eggs decrease with women age. Possible causes of age-related fertility decline not only related to egg quality. We have mostly one part of problem dependent of egg quality, but second part not dependent of egg quality. Depending on egg quality, it is mostly meiotic problem, abnormal fertilization, cleavage, etc. Genetic abnormality of eggs, problem of egg cytoplasm, and decrease of number of eggs, decrease of ovarian reserve. Not dependent of egg quality, it is mostly general health problem like diabetes, hypertension, heart disease, myoma, endometriosis, infections, etc. Okay, all this sure is very individual. We cannot say exactly when the reproductive age ends. In some articles published, the clinical cases of successful pregnancy at 47, 48 years old, even one publication around 56 years old. But in most of cases, we have decrease of fertility after 41, 42 years old. Why our eggs are getting worse with age? In this slide, you can see the report of American Association of Reproductive Medicine, and it is very interesting to see that first graph, blue, signify that we have possibility to have retrieval. Women less than 35 years old is around 100%. And last one, it is live birth rate. It means that go home with a baby. And the difference between this and this at 44 years old is not very big. The main difference is between these graphs. So it is not enough to receive eggs. It is not enough to have transfer. Yeah. The second one, it is probability to have transfer. Also, it is not changed so dramatically. But the most big problem due to quality of oocytes is to pregnancy rate. At 35 years old, it is around 50%, and after 40, less than 10%. And also main point, it is live birth rate, because the probability to have miscarriage also increase with woman age. The main mechanism of aneuploidy in embryos, we can see the four main mechanisms. Male partner, it is from 10 till 20%. It is quite important and depends on sperm quality, male partner's age, and a lot of other things. But other three, graphs concern of woman eggs. Meiotic 1, meiotic 2, it means that it is quality of egg during final maturation. Mitotic, it is the quality of embryo after fertilization. So 70% of all problems of developing of embryo related to egg quality. How many embryos need for one euploid? What does it mean? What does it mean PhD? We will talk a little bit about this, because now we have possibility to make some specific genetic analysis of embryo and even of eggs, and understand before to transfer this embryo in uterus the quality and if this baby will be healthy or not. So, if we analyze this graph, we can see the number of embryos which are aneuploid. It means with abnormal genetic, abnormal number of chromosomes. When embryo have abnormal number of chromosomes, it will not implant, or if it implant, it will provoke spontaneous abortion, or baby may be ill after born. But in most of cases, it will not implant. So we can see that at very young woman age, the number of aneuploid embryo is quite high, around 40%. Then from 26 till 31, it is the lowest level of aneuploidy, and maybe it is the best age to have a baby, as minimum first baby. And after 31 years old, we can see that this graph increase every year a little bit, and around 42, 43, 44, we have mostly 90% or sometimes 100% of embryos with genetic abnormalities. So if women have young age, for example, less than 30 years old, to have as minimum one euploid embryo, need to have around 2 eggs. But if women have more than 41 years old, we should have as minimum 6. And if you would like to have 2 euploid embryos, you should have 12. But the problem that in this age, in most of cases, we have around 3-4 eggs for egg collection. That's why the probability of pregnancy decrease. So let's talk a little bit about mitochondria. What is it? Why we are talking about it? So the role of mitochondria is produce ATF molecules. This is the main energy source of cell. And these mitochondria contain one or more mitochondrial DNA, which about 16.5 kilodalton in length, and encode 13 proteins. So after fertilization, the mitochondria of sperm rapidly degenerate, and in embryo, mostly women mitochondria live. That's why was made very interesting investigation of human migration, because scientists can analyze how people move in the earth, and like that made some prognosis and explain that we are all providing from one woman from Africa. But okay, maybe later it will be changed, this theory. So today the correlation was found between amount of mitochondrial ADN and age of woman. With age, the amount of mitochondrial ADN is decreased. About mitochondrial ADN and fertilization rate, less mitochondrial ADN we have, worse fertilization we will see. Amount of this ADN and aneuploidy, because embryo have no enough energy to correlate some mistakes and to moving forward. And also between amount of mitochondrial ADN and blastocyst formation and implantation rate. Role of mitochondria during aging. We can see that during our life we have some kind of degradation of number and function of mitochondria, and finally when they cannot working well, we will see cell death. Low concentration of mitochondrial ADN we found in patients with low ovarian reserve and advanced reproductive age, and it is around twice. Mitochondria take part in most of intracellular events: ATF production, apoptosis, metabolism of calcium, etc. Low mitochondrial mass of oocyte may decrease the result of infertility treatment. It can provoke in embryological laboratory stop of development of embryo, implantation failure, and provoke chaotic mosaicism. That's why some techniques were studied. We call this technique generally mitochondria donation. We can do this donation by different way, but in last time we prefer to doing pronuclear transfer. It means that we take fertilized nucleus of woman and put inside of donor oocyte, where we have good number, good quality, and good function of mitochondria. But genetical material, main genetical material, will be from this woman or from this couple. So, what else can we do, not by medical way, but changing lifestyle? Of course, we can do a lot of things. Some articles write that some interventions like vitamins, like healthy lifestyle, like general health condition, previous pregnancy, can improve and increase a little bit the quantity and quality of eggs. We have not a lot of really scientifically proven things in this field. Recently was one very interesting publication about relationships between hypocaloric diet and number and function of mitochondria. It was a study with laboratory animals, with mice, and it was shown that hypocaloric diet, less than 40% in comparison with average everyday ration, normalize number and function of mitochondria in obese mouse. Also, it was shown that hypocaloric diet improved the spindle abnormalities. Spindle, it is the specific structure in cell which help to make cleavage, division of cell. And if we have abnormal spindle, we will not have normal embryo. So normalize amount of calorie intake in obese mouse show to improve dramatically the quality of intracellular process. So as minimum what you can do, according to this study, to have a health diet, and if you have some problem with weight, you can try to normalize your weight. So, future of infertility treatment. I think it will be more or less routine to make donation of mitochondria, like spindle transfer, pronuclear transfer, transfer of donors, or autolog mitochondria. Also, a lot of works now study stem cells activation, formation de novo of oocytes, regulation of antral follicular atresia, because all women born with all oocytes, and all life we only spend our oocytes. Maybe if will be found how to regulate this spending, to decrease this spending, we can have full stock of oocytes till our 40, 50, 60 years old, who knows. Also interesting publication concern of formation of eggs from somatic cells. So, but it is the future, and now we have some solutions with proven fertility for poor responders patients and patients with advanced maternal age. So, we can do several stimulation, multiple stimulation with freezing eggs and made own banking for this patient. And like that, after you can use your eggs later when you can have time and you will be more available for that. We have special embryological technique like calcium nanophore. Birol will explain better than me about this. Also, we have egg donation program. We can use eggs of another girl, egg donor, fertilize these eggs, and then to care pregnancy with embryo provided from donor eggs and husband sperm. And also we have surrogacy program. So thank you for your kind attention. I hope it was more or less clear. If not, I will be happy to answer all your questions.
Thank you very much, Dr. Galina. It was very interesting.
You're welcome.
And I see interest between our participants.
Okay.
For example, we can move to questions that we received. Question to Dr. Galina. Can you please recommend some vitamins or medications that increase the quality of oocytes?
Okay, thank you for your interesting question. You know, there is a huge number actually in the market of different kind of vitamins and microelements, preparations, some kind of complex, etc. The main purpose of all this complex is folic acid, vitamin E. Also, some of them contain a little amount of androgens, because it was shown in some study that little amount of androgens can decrease the apoptosis of eggs. Also, should be some kind of microelements like selenium, like what else? I think L-carnitine also often the producer added in this preparation. So something of this kind. But another study shown that when you take, how to say, artificial vitamins, it is working less good than you try to regulate the amount of these vitamins and microelements by intaking correct food. Because these vitamins, they exist in different isoforms, and commercially existing vitamins contain mostly 1 or 2 isoforms. And in nature, it may be 5, 10 different kinds. So better to try to have healthy diet and regulate like that.
Okay, thank you. I'm 43 years old. My IMH is 0.7. Is it still possible to get pregnant on my own cells? I have had a son in natural way when I was 36 years old.
Okay, thank you for your question. Very interesting question. And it is quite often that we have such kind of questions. The statistics say that at 43 years old, in average, we will have around 85–90% of all embryos with genetic abnormalities. With IMH 0.7, each stimulation we will be able to receive maybe 4, maybe 5 eggs. So statistically speaking, the probability is not very high. But in your situation, the good prognosis that you have been pregnant and have delivery of healthy baby. So women who have previously been pregnant and delivered the baby has better prognosis than women who never been pregnant. So this is very good things. And nobody knows the quality of your eggs before we try to retrieve them and try to see their genetics. So in your case, it may be absolutely possible, but if we will analyze 100 of such cases, maybe statistic will not be very good.
Okay. The question to embryologist, Pirolaidin, what day do you recommend for biopsy for PGD? 5, 3, PGD 5, 3 of the 3rd of 5th day, it means maybe.
Thank you for the question. Pre-implantation genetic diagnosis, there is 2 strategies already we are doing. We are doing biopsy, trafectoderm biopsy on 5th day of blastocyst stage, or we are doing blastomer, single blastomer biopsy on the 3rd day of embryo development. So there are basically difference between 3rd day of biopsy and blastocyst trafectoderm biopsy, number of the cells. Because with blastomer biopsy, we can determine only one cell. There is risk to don't recognize and to don't get signal from this one cell. So in this case, this embryo will be like undefined. Advantage of trafectoderm biopsy, we can take 3 to 5 cells. So if one cell doesn't have signal, we have still possibility to get signal from other cells. Another advantage, we have possibility to understand about mosaic rate of embryos. So basically, blastocyst trafectoderm biopsy always getting better advantage than 3rd day blastomer biopsy. One of the important things also, of course, time consuming and financial consuming of trafectoderm and blastomer biopsy. Because when we take the blastomer biopsy, we are not aware this embryo will develop the blastocyst stage or not. But when we do trafectoderm biopsy, we already know this embryo on the blastocyst, and there is a potential for the pregnancy and for the freezing, cryopreservation. In this situation, of course, I suggest a trafectoderm biopsy is more effective and more successful than 3rd day blastomer biopsy.
Thank you. There is a question to Dr. Strelko. I just turned 30 years old and my doctor said I have a low ovarian reserve. Is it an indication of low quality of the eggs? Is there anything that can be done to increase my ovarian reserve?
Thank you. Very, very interesting question. Very often people and doctors saying that low ovarian reserve mean low quality of eggs. It is absolutely wrong. You can have very few number of eggs, but good quality, and you can have just opposite, very big amount of eggs and bad quality. The quality of eggs mostly depends on your age. If you have no treatment such chemotherapy or some radiation or some toxic treatment, for example, for cancer, your quality of eggs should be good because you have 30 years old. That's why. And what to do to increase the quality? Okay, it is also quite difficult question. We can try to increase a little bit the quantity of eggs, but for some short period. Because as I mentioned before, all women born with all eggs. And it is the maximum number of eggs, it is 7 million. in first months intrauterine life, and after delivery you only lose your eggs. So you cannot increase the general number of eggs. You can also try to influence the speed of atresia of these eggs. There are some kind of technique. You can try to improve the blood circulation, like some sport activities, some special diets, some medication which improve microcirculation. Also, sometime when women have very low ovarian reserve, we can prescribe for 2-3 months replacement hormonal therapy. And estrogens can decrease a little bit the speed of atresia. But okay, it will have not very important influence and not very long lasting. So we can do that like 2-3 months before stimulation, try to receive eggs, try to freeze or try to fertilize, and then receive pregnancy like that.
And there is
one more suggestion. Now we developed the new technique of ovary revitalization. We can the name of this technique is PRP therapy. So we can take blood from vein, then prepare by special way and put inside of ovary little amount of these concentrated lymphocytes, and in 2-3 months it can provoke the improvement of number of antral follicles, but also it will not last very long, like 3, 4, 5 months.
Okay, and one more question. Which type of stimulation is more appropriate for me if quality of my oocytes is bad?
In this case, we try to change the stimulation. It is better to use medication which contain LH. Normally in such cases we use urinary gonadotropins, or sometimes we use medication like pergaveris containing LH. Also, we often propose to our patients growth hormone, because it is improve the sensitivity to stimulation and improve finally the number of eggs and quality of eggs. Also very important, the last injection before the egg retrieval, we call this injection trigger. We are doing in this case double trigger. It means HCG and agonist of GnRH, because they are working by different way and provoke more physiological increase of LH and more physiological stimulation of LH receptors in ovary. And thanks to this technique, sometimes we receive eggs of better quality. After, embryologists also working by special way with this kind of eggs. They add, for example, calcium ionophore. Beryl can explain this. And it may improve fertilization and cleavage rate.
Okay, maybe Birol can finally explain us about calcium.
Okay, actually is the main question in the embryology laboratory when we receive the oocytes, the quality of oocyte. Till the fertilization process, we are trying to do our best and to prepare this oocyte for the high quality of level and actual size and quality of zona pellucida, which will allow to us to make better intrastoplasmic sperm injection. Of course, when age is increasing on women, quality of perivitellin space, quality of cytoplasm, and quality of oocyte wall is decreased. So we have additional artificial techniques which we are using in laboratory to increase the capacity of oocyte. One of them is additional calcium activation. So what is the main key point of calcium? Calcium is helping the oocyte to get better compact cytoplasma, which is giving a main energy to develop the embryos. Also is giving chance that the main transport between mitochondria and regular DNA. So that's why we are trying to increase calcium level and activation in the oocyte and to get better IVF outcome and fertilization. While according to our statistic, which we are using calcium activation, we always increase the fertilization rate up to 10% and high quality of blastocyst rate up to 10%, and we dramatically increase euploide blastocyst rate. Why increase euploide blastocyst rate? Because we are directly affecting mitochondrial activity. So that's increased the chance of quality of DNA, and we eliminate by this way the high percentage of DNA, sperm DNA fragmentation during the fertilization, and this helps to achieve high quality of blastocyst and euploid blastocyst.
Thank you. And there is another question to you. Can a man with a sperm DNA fragmentation of 80% expect a successful IVF cycle? What can you offer in this situation?
To be honest, I am the one of the embryologists who doesn't believe so much the male factor. But I have to say one of the main questions on the male factor is not concentration, not exactly morphology, but sperm DNA fragmentation. Sperm DNA fragmentation directly affecting the quality of embryos. There are different techniques how we can determine and how we can fight with sperm DNA fragmentation. Of course, basically the main suggestion who will go under IVF treatment to have sperm DNA fragmentation test. If sperm DNA fragmentation test is more than 30%, which is high level of sperm DNA fragmentation, we should use additional techniques which will help to decrease possibility of fragmented DNA sperm, which we are using for cytoplasmic sperm injection. So the best of the technique is to use sperm chip technology. This technology is allow us to find best possibility for the low DNA fragmented spermatozoid. Because under regular microscopic techniques, we are not able to find out under microscope which sperm has DNA fragmentation or which not. There is not such technique in the IVF field. Only the possibility how we can decrease this chance. And this is one of the best technique to use sperm chip technology and to get this chance lower and lower. So according our statistic in our lab, which we are going under sperm DNA fragmentation high level, which we use sperm chip, we get better IVF outcomes and better pregnancy rate than regular X outcome.
Thank you. And there is a question to Dr. Galina. I'm 38. I would like to freeze my eggs in order to use them a little later. Does it make sense? Are 30-year-old woman oocytes quality suitable for freezing?
30 or 38?
38.
38. Okay, interesting question. Social egg freezing, this is a big topic. Maybe next time we will discuss more widely about this topic. Of course, it is a good idea to freeze eggs, and better to freeze eggs at 38 years old than at 42, for example. The probability to have pregnancy with these eggs depends on quality and number. There are some calculations, some statistic, how many eggs we need to have 1, 2, or 3 children according woman's age. I am not able now to find this quickly, but it seems to me that in this age to have as minimum 1 child, better to freeze around 25-30 eggs. We have done some scientific study of donors' eggs in our laboratory, and I can say that around 30–40% of donors' eggs, it means the eggs of very young women, maybe not good for freezing because they can have some abnormality of cytoplasm, of zona pellucida, of some intracellular structure. That's why before we receive the eggs of patients, we are not able to say which quality of these eggs and what is the exact prognosis of freezing and future thawing of these eggs. We cannot say you exactly that you will have a result after your freezing or not, but it is very good idea to make actually stimulation and freeze your eggs. And if you will have not enough, for example, 2, 3, 5, maybe will be good to repeat 2–3 times the stimulation and try to freeze more. After you will done as minimum one procedure, your doctor will be able to say, okay, your eggs are excellent, we have 15, it's enough, that's all. Or for example, your eggs is not so good, so try 2–3 times more.
Just I want to add something on this topic. When age is increasing, of course, quality is low, but from technical way, we are using vitrification technique in the laboratory, and every laboratory has different protocol, different experience, but in our experience, even in the low condition of low quality of oocyte, still survival rate is very high. So still we have chance to freeze these oocytes and to thaw well. But of course, quality of embryos and pregnancy chance, questionable.
Thank you. And maybe our last question, or not last question. We have new lot of questions. Okay. I have question about embryos, their quality 4AB and 4BB. What mean these letters and numbers? Should I transfer one embryo or two in this case?
Okay, that is embryos. Yeah, this is embryo scoring. So embryo scoring we are doing according to the size of blastocyst. How bigger, how smaller. 4 is 4, 5, 3, 4, 5 is starting from 2, 2, 3, 4, 5, and 6. So this is the size of blastocyst. Second is quality of trophectoderm, which is protecting ICM, which carry up the actual DNA. And last one is the ICM. So 4AB, that means 4 is a good size on the 5th day of embryos. A is good trophectoderm quality, which is protecting the DNA area. And B is ICM quality. Okay, this is the second quality of ICM. That means we didn't recognize under the microscope quality of DNA well. And 4BB even lower quality because DNA and plus trophectoderm site is not clear. But there is no means this kind of embryo doesn't have chance for the pregnancy. Of course there is. This is kind of scoring criteria for embryologists. It is a strict criteria. Of course we can say 4AA quality embryo have more chance than 4AB quality of embryo, but depends of genetical answer. So these embryos, if this embryo didn't have genetic test, NGS or PGD, still there is questionable 4AB is better or 4AA, because there are many embryos, high quality, but they are not euploid, they are not good. Still there are low quality of embryos, but they are euploid and they can give pregnancy. About number of pregnancy, okay, it is not just to talk about number of embryo, it's also quality of endometrium. Dr. Galina will give a better information about quality of embryo. But of course, we are deciding number of embryo which we are transferring depends of quality of embryo, depends of quality of endometrium. So let's say, according to me, we can say 60% of the embryo quality, but still 40% of the endometrial quality. I am always part of single embryo transfer because, okay, it is not only to get pregnancy, but to continue to following the pregnancy, still there are different questions for the IVF specialist and patient. But number of embryo should be according decision of embryologist and gynecologist medically, and from the patient, like emotional.
Okay, and maybe final question.
I'm sorry, I found the slide about fertility preservation. If you want, I can try to show you. Okay, it is a little bit difficult, but I will try. Okay, this one. Just a minute, you will see. Okay, this graph, yeah? The number of eggs, number of mature eggs, probability of pregnancy, age 38, 40. So to have around 50% probability of pregnancy rate, one baby, around 14 eggs. To have probability about 80%, the same age, 30 eggs. So, sorry, Nadezhda, I interrupt you, but I would like to show this.
Very interesting. Okay, that was the last question.
Yeah,
to embryologist. My embryos died on 4th day. The reason is bad quality of oocytes. How can we avoid this? We also want to know the gender of embryos.
Okay, if some embryos stop on the cleavage stage or 4th day stage, so that can be several different reasons. So metabolic reason, which we will never be aware to find out. Genetical reason, we can understand only with genetic test. We should take biopsy from embryos. Of course, it can be happen because of quality of oocyte or quality of genetically quality of spermatozoid. So it's hard to say why this embryo stopped. And also, of course, laboratory condition, culture media, techniques, experience of embryologist can affect this. What was the second question?
The second question was the patient
sex gender.
To know the gender.
Sex selection.
Of course, it's possible. It's possible for both way, for PhD testing with 5 chromosomes and also with NGS testing. So what is the difference? NGS testing is giving sex gender plus more details about all chromosomes. PhD5 is giving answer sex gender plus 5 necessary chromosomes, which is responsible from unemployed some of the mutations and also implantation.
Thank you very much. Thank you to Doctors Galina. Thank you to Birol. It was very interesting. I hope it was interesting for our visitors. And now we will finish our webinar and hope to see you next week. Hope that this topic that I proposed you will be interesting for you and for your friends. So please, you're welcome joining us next week. Goodbye.
Goodbye. Thank you for your kind attention. Waiting for us the next week. Bye-bye.
Stay safe and stay home.
Yeah, it is important. And be healthy.